Hello, everyone, and welcome to our question lab. We're happy to have you here. Tonight's topic is neurology, and leading our session once again is Dr. Paras Vakaria, and Paras is going to introduce himself now.
Thank you, Sean. Hey guys, my name is Paras. I'm a dermatology resident at UT Southwestern here in Dallas, Texas. I originally graduated from pharmacy school and then went back home to Michigan to do medical school. I am also an RX coach working with USMLE-Rx. So I work with students to help prepare them one-on-one for the USMLE Step 1 as well as Step 2 CK, and I'm happy to help lead tonight's session.
I know I mentioned RX Coach earlier. RX Coach is our coaching and tutoring program. We'll talk more about that later, but what I do want you to know now is that the methodology and the process we will use as we approach and tackle these 4 questions this evening will be the same process and method that we use during our coaching sessions. So let's go ahead and get into our first question of the evening. As you can see here, the answer choices are removed. They have been removed. That is by design. We do that because we don't want the answer choices to guide or dictate your thought process, and we don't want you to see an answer choice that you are unfamiliar with, which may cause you to panic or doubt yourself as you're reading the vignette. Once we cover up the answer choices, we will begin and read the lead-in. We read the lead-in first because we want you to know what the vignette and the test writer are asking, so you know what to look for in that vignette, so you can pick up on all those relevant clues without having to reread that question and waste time. So let's do that now. Which of the following pathologic changes would be most likely in this patient's brain? Which of the following pathologic changes would be most likely in this patient's brain? Once we read the lead-in, we like to ask our students how many steps they believe this question will require. An example of a 1-step question could be where you're asked for the diagnosis. An example of a 2-step question is when you're asked for the treatment for a diagnosis. And an example of a 3-step question is where you are asked for the mechanism of action for a treatment for a diagnosis. So I'll give all of you a few seconds here to respond in the question box and let us know how many steps you believe this question will require. And then we will go ahead and read the vignette. I see the responses coming in. Let's go ahead and read that vignette. A 75-year-old man comes to the clinic with 3 months of weakness in his hands and shoulders and difficulty swallowing. His first symptom 3 months ago was in the left foot, which then progressed to the right foot and then both arms and hands. He is unable to hold a pen or pick up small objects with either hand. His left foot drags on the ground when he walks. Physical examination reveals bilateral leg weakness and foot drop, worse on the left. He has mild hand weakness with atrophic intricate hand muscles. He has decreased deep tendon reflexes in the lower extremities and hyperactive reflexes in the upper extremities. Scattered muscle twitches are observed in the arms and legs. His speech is mildly slurred. When asked to drink a glass of water, he coughs and is unable to drink it quickly. Which of the following pathologic changes would be most likely in this patient's brain? I want all of you to start thinking about the important and relevant clues in this vignette as I hand it off to Paras.
Thank you, Sean. So what we're going to do is we're going to go ahead and walk you through what we think are the important clues in this vignette and the lead-in. And you can see there, and as Sean was reading the question, there was a lot of information in that vignette, okay? So let's work our way through it. So demographics, whenever you're given demographics, that's automatically going to start giving you some clues about what may be going on. So always important to make note of that. And then why did he come to the clinic in the first place? Why did they come to the emergency room? Why were they sent to the hospital? So those signs and symptoms are always important, but also the duration of those symptoms. So we know this has been going on for 3 months, okay? Now, this is a neurology-specific question lab, so it is important to take note of all those neurologic abnormalities that they're telling us, because we may have to piece all of that together to come up with an explanation. So when they're telling us about, not being able to pick up objects, having foot drop, having atrophic hand muscles. We are going to have to piece all of that together. You know, they give us some information about reflexes, muscle twitches, all important to take note of there, okay? And you can see that there's a lot. There's a lot there, but it's going to be important to try to use our knowledge of neurology to figure out what's going on, okay? So then when we get to that lead-in question, it's asking us a pathologic change we would see in the patient's brain, okay? So how many steps is this question? Well, one, I think we need to figure out what's going on in this patient, what's the condition, what's the diagnosis, and then two, what is the mechanism or pathology behind that condition or disease? So I think a two-step question, you know, based on how the answer choices are worded, there could be a third step to it, but I think one, we need to figure out the diagnosis, two, what is the pathology behind that diagnosis? So let's go ahead and take a look at those answer choices. And what we're going to do is we're actually going to work our way from the bottom up to the top. You see 5 answer choices. And we're going to start with answer choice E and work our way up to answer choice A. And we recommend that students do this because, you know, sometimes we'll see students starting at the top, they'll see something they like, and then they'll select that without having gone through all the choices. So doing it this way makes sure you get through all the choices and that you're not biasing yourself. So we'll go ahead and do that now. Answer choice E, Wallerian degeneration of the lateral corticospinal tract. D, destruction of oligodendrocytes. C, demyelination of peripheral neurons. B, cell death in the substantia nigra. And A, accumulation of amyloid plaques. So we're going to go ahead and open up the poll. Go ahead and select the answer choice you think is the best answer here, and we'll talk about it in just a few seconds.
Excellent. Thank you, Para. So once again, we're going to wait until about 2/3 of you have responded before we close the poll. Remember that there is no penalty for guessing on test day, and certainly not tonight. So even if you're unsure, don't worry, take your best guess, and then we will go over the correct and incorrect answer choices afterwards. I see the responses coming in. A few more seconds here. All right, let's take a look and see what you selected. Looks like 39% of you selected Wallerian degeneration of the lateral corticospinal tract, and in second place was demyelination of peripheral neurons. So let's take a look and see what the correct answer is, and the correct answer is indeed E, and 39% of you got it right. So great job to those of you who got it right. If you didn't, don't worry, we're all here to learn together. And even if you did get it right, let's make sure you got it right for the right reasons. And Boris is going to explain it to us now.
Thank you, Sean. Great job, guys. Definitely a nice question here, but also a difficult one. So let's take a look again at the vignette. So this patient is presenting with some important neurologic symptoms and signs, okay? They started in the feet, and then they spread to the arms and hands, and then even progressed to having difficulty swallowing, okay? He has a variety of pathologic neuro signs and symptoms. Some of them are lower motor neuron signs. You can see there they talk about atrophic hand muscles. They talk about fasciculations. They even talk about decreased deep tendon reflexes in the lower extremities. Some of them are also upper motor neuron issues, though. You can see the hyperactive reflexes in the upper extremities. So we have a combination of upper motor neuron and lower motor neuron issues. And with the progression that also now involves difficulty swallowing, the one thing you really should be thinking about is ALS, or amyotrophic lateral sclerosis, okay? So patients typically present with slowly progressive weakness that affects the arms, the legs, and the bulbar muscles as well, okay? And on the next slide, Sean has actually gone up, and actually this first slide, this is talking about kind of the basic neurophysiology, but what is Wallerian degeneration, in case that phrase was throwing you off? Well, that's basically what is happening to the nerve when it gets injured. So that's essentially part of the pathology of ALS is it's the nerve degeneration, and that's kind of the mechanism. And you can see a little bit of a picture there in that injured neuron diagram. On the next slide is a table about ALS, okay? And so you can see there, it's a combined upper motor neuron and lower motor neuron degeneration, okay? So some of those deficits our patient had: fasciculations, atrophy, dysphagia, trouble swallowing. The patient also had some upper motor neuron deficits, hyperreflexia, limb weakness as well. So that's really the best diagnosis here is upper motor neuron degeneration. And then when we think about the pathway, that would be involving, one of the pathways involved would be the lateral corticospinal tract. That's one of the upper motor neuron pathways, okay? So that, when you look at the answer choices, and we'll kind of go back to the question here, is you can see that that's one of the upper motor neuron tracts that is involved in ALS, okay? And you can see it's also listed in that table there as well, under characteristics of the upper motor neuron tracts, corticobulbar and corticospinal, okay? So let's talk about the other answer choices real quick and why those would be incorrect. So destruction of oligodendrocytes, so that's getting likely at multiple sclerosis. So with that, you know, you're looking for multiple neurologic complaints that can't be explained by a single lesion, and then maybe you were having some difficulty piecing this all together and you're like, maybe this is MS. And so that is where you have destruction of oligodendrocytes. But some key things with that that we don't really see here would be eye issues, so optic neuritis, diplopia, and so we're not really getting that. Answer choice C, demyelination of peripheral neurons. I think this was the second most highly selected answer, and this is something you would see more so in Guillain-Barré syndrome, okay, or GBS. It is more of an acute process. It is rapidly progressive, and it's a demyelinating disorder of peripheral nerves, okay? So patients typically present with rapidly progressive paralysis, paresthesias, and also decreased reflexes, and it's ascending, so it kind of starts at the bottom and works its way up a little bit as well. Answer choice B, that's likely getting at Parkinson's disease, which is more of a movement disorder. So you would have tremor, a resting tremor, rigidity, bradykinesia, a shuffling gait, things that we're not really told about here. And then lastly, answer choice A, that's likely getting at Alzheimer's disease. So that's a type of dementia where you have memory loss, you can have depression or language deficits, not really what we're seeing here. So the best answer is ALS, and then going a step further to pick up on which tract is involved and what's the pathology behind the disease.
Excellent. Thank you very much, Paros. A challenging question indeed. But like I said, this is a learning process, and you will have challenging questions on exam day, whether those exams are in block exams while you're in medical school or on the USMLE or COMLEX. So it is important that we practice them and are comfortable answering them. So let's go ahead and move on now to our second question of the evening. Once again, the answer choices are covered up. That is by design. And we will begin with the lead-in. Which of the following symptoms is this patient most at risk of developing? Which of the following symptoms is this patient most at risk of developing? I'll give all of you a few moments here to respond in the question box and let us know how many steps you think this question will require. And then we'll read the vignette. All right, I see the responses coming in. Let's go ahead and read that vignette. A 61-year-old man comes to the clinic with a prickling sensation in his toes and tripping while walking for the past 6 months. He has type 2 diabetes mellitus variably controlled with metformin. His recent hemoglobin A1C was 9%. On physical examination, he has diminished proprioception, light touch sensation, and vibratory sensation in his feet. Which of the following symptoms is this patient most at risk of developing? I want all of you to start thinking about the important clues in the vignette and lead-in as I hand it off to Paris.
Thank you, Sean. So once again, we will go ahead and show you what we think are the important clues in this vignette and the lead-in. So again, demographics, so 61-year-old man, always important to make note of that. And then why did he come to the clinic? Well, they told us, okay? And then also the duration, also important to make note of. They then tell us that he's a type 2 diabetic, and then give us an interesting phrase, variably controlled. That's always interesting whenever they say word something like that. Always question, why are they telling it to us like that? We then know what his hemoglobin A1C is. We're given some physical exam findings. All important. So now we go to the lead-in. So then it's asking, what symptom is the patient most at risk of developing? Well, how many steps is this question? Well, I think one, we need to figure out what's going on with this patient. And then two, what other thing could he be at risk of? So I think probably a two-step question here. So let's take a look at those answer choices. Answer choice E, and once again, we're going to start at the bottom and we're going to work our way up to the top. Answer choice E, tremor. D, muscle twitching. C, muscle cramps. B, dystonia. And A, dizziness when standing up. So we're going to go ahead and open up that poll. Go ahead and select the symptom you think this patient is most at risk of developing, and we'll talk about it in just a few seconds.
Excellent, thank you, Paul. So once again, we're going to wait until about 2/3 of you have responded before we close the poll. As always, we do have a raffle at the end of tonight's session, so make sure you stick around because you must be present to win. I see the responses coming in. We'll give you a few more moments here. All right, I see them coming in. A few more moments here. Next week's topic, for those of you who are interested, is going to be psychiatry. All right, let's take a look and see what all of you selected. Looks like in first place we have dizziness when standing up, and in second place was muscle cramps, closely followed by dystonia. So let's take a look and see what the correct answer is. And the correct answer is A, dizziness when standing up, and 36% of you got it right. So great job. This was a tough question. Well, let's make sure we understand why the correct answer is correct and why the incorrect answers are incorrect. Boris.
Thank you, Sean. Yes, great job again, guys. So what is going on with this patient? What is that first step? Well, not just knowing that he has diabetes, but that it's uncontrolled, okay? So he has a high hemoglobin A1C. He has neurologic signs and symptoms, diminished proprioception, sensation, vibratory sensation. So he probably has diabetic neuropathy, okay? So he's actually getting altered change to his nervous system because of his diabetes, okay? So he's got diabetic neuropathy. Why does that happen? Well, in patients with diabetic neuropathy, you essentially get also demyelination of those nerve fibers. So you have small fiber sensory loss, which is kind of what he has. He has some diminished light touch sensation, okay? It begins with the longest nerve fibers. So that's why the toes and feet are usually affected first, okay? And this also damages the autonomic system as well. And you can get autonomic neuropathy. And it can lead to a few things, such as postural hypotension, or dizziness when standing up, okay? So how does this happen? Well, normally when you stand up, there is vasoconstriction that occurs to maintain your blood pressure, okay? Now that's normally. However, in patients with diabetic neuropathy, you can have damage to that autonomic system that regulates that. So remember, as part of the autonomic system is the sympathetic function. So in this case, dysregulation of that sympathetic system means that you do not get that vasoconstriction when you stand up, okay? So it would lead to a drop in blood pressure, it would lead to a rise in heart rate, and you would get dizziness when standing up, okay? Autonomic neuropathy can also lead to abnormal sweating, it could lead to impotence, gastroparesis as well. If those were other options, those would also be good choices, but of these answer choices, answer choice A is the best one. But let's talk about why the other ones are also incorrect, okay? So a tremor, that would be something if you were having damage to one of the brain movement control areas, like the cerebellum or the basal ganglia, okay? It can also be essential or primary, but we're not really given those clues. Muscle twitching and cramps, those are symptoms of motor disease, not sensory disease, okay? And we've determined that this is a sensory deficit in this patient. Answer choice B, dystonia, that usually results from medication, so antipsychotics or other CNS issues, not what's going on here in this patient. So the best answer is picking up that this is diabetic neuropathy, and that also knowing that it can affect the autonomic nervous system, so you can get dizziness when standing.
Excellent. Thank you, Boris. Once again, a challenging question indeed, but we're here to learn. So let's go ahead now and talk briefly about RX Coach. I mentioned to you that RX Coach is our tutoring and coaching program, and you know, a lot of students have come to us for help, whether it's with, you know, helping them make a study schedule, and then helping them stick to it and hold them accountable, right? So in our sessions, what do we do? Well, your tutor, your coach will set up a personalized study plan for you based on your incoming assessment or based on your syllabus if you're still in medical school. They'll tell you what to do for a certain subject matter, and then when you've completed those tasks, you'll meet with your tutor and review that subject matter. You'll be able to ask your tutor any questions you have key concepts explained to you, and then you'll do practice questions together. Now, unlike today, we'll be actually doing it individually, so we'll ask you what you believe is important, what your train of thought is like, what's on your list of differentials. So you'll learn a lot with each question that you do, but as you do each question, we can really get to identify your strengths and your weaknesses and bridge those knowledge gaps, and also work with you individually on your test taking skills. And that individual attention, that process has been so successful that every single student that has come to us so far has accomplished their goals. And that's a very strong statement. And we've done that by maintaining a 4.9 out of 5 satisfaction rating. So that speaks volumes about the great work that our coaches like Boris and Alec are doing. Now, sometimes people come and say, well, I'm doing fine in my classes, I'm doing fine on my STEP, but I want to do even better. And we're here to do that. You know, sometimes people come to us that graduated 10, 15, 20 years ago, and they say, you know, this is my target score. They come to us and say, I'm already at a 220, but I want to get to a 250. Whatever your goal is, whether you're in dedicated or not, whether you're a first semester student or not, whether you're studying for USMLE or COMLES or even for a comprehensive exam, RX Coach is here to help. So if you want the individual guidance of a USMLE expert, somebody who's already been through what you're going through and is where you want to be, reach out to us at rx-coach.com. That's rx-coach.com. Our students always tell us that by coming to us, their studying has become more efficient and they've accomplished their goals much quicker because we take the guesswork out of studying. Instead of you trying to figure out what you should be doing or asking your friends or your peers or your colleagues, we as experts can step in there and tell you exactly what to focus on, save you time, and get you to where you want to be. So once again, that website is rx-coach or rx-coach.com. You can visit the website, click on the free consultation tab, and you'll have a free consultation with me to talk about the program and how it can benefit you. If you want generalized advice, you can visit us at firstaidteam.com. Now, Jeff is going to put in the chat box here shortly our topic for our next webinar, which is going to occur later this month. And once again, you can find that information also at firstaidteam.com. I'm not sure if it's there yet, but it will be soon. And our topic for our next webinar with Dr. Tao Lee and Boris and Alec is going to be on how to create a study schedule. So we encourage all of you to attend. All right. So let's go ahead with that and move on to our third question of the evening. Once again, the answer choices have been removed. That is by design. And we'll begin with the lead-in. Occlusion of which of the following vessels would most likely produce these symptoms? Occlusion of which of the following vessels would most likely produce these symptoms? I'll give all of you a few moments here to let us know in the question box how many steps you think this question will require, and then we'll read the lead-in. All right, I see the responses coming in. Let's go ahead and read that vignette. An 80-year-old man comes to the clinic with occasional loss of consciousness when tilting his head back. He has diabetes and hypertension, along with a 50-pack-year smoking history. History includes a left carotid endarterectomy and surgical repair of an abdominal aortic aneurysm several years ago. It is determined that the patient is likely experiencing transient brainstem ischemia when he extends his neck. Occlusion of which of the following vessels would most likely produce this symptom? Once again, I want you to start thinking about the important clues in this vignette and the lead-in as we hand it off to Paras. But before I do, I see a lot of people jumping ahead with the answer. Keep in mind, it's important to have that process in place so you're always consistent. This isn't a race. It's about performing the best we can and getting as many points as possible on every exam we take. Paras.
Thank you, Sean. So once again, we will go ahead and walk you through what we think are the important clues here. So again, demographics. This is another elderly gentleman, okay? Why did he come to the clinic? Well, occasional loss of consciousness when tilting his head back. They gave us some pretty important history on him, all important to take note of here. And then the very end, also an important clue there, that they actually determine what is going on with this patient. When he extends his neck, he's experiencing transient brainstem ischemia. So obviously very important to take note of that and highlight that. So now when looking at the lead-in, it's asking occlusion of which vessel would produce these symptoms. Okay, well, how many steps is this question? Well, one, I think we need to figure out what's going on in this patient, what's the diagnosis, and then two, what vessel could be involved where occlusion would lead to that. So probably a two-step question here. One, what's the diagnosis? And then two, which vessel is involved? So let's take a look at those answer choices. And once again, we've got a few answer choices. We're going to start at the bottom and work our way up to the top. Answer choice E, subclavian arteries. D, internal mammary arteries. C, internal carotid arteries. B, external carotid arteries. And A, anterior spinal artery. So once again, we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is most likely correct, and we'll talk about it in just a few seconds.
Excellent, thank you, Paras. So once again, we've got that poll open. We'll wait until about 2/3 of you have responded. A friendly reminder though, that next week's topic is going to be psychiatry. And of course, we do have a raffle at the end of tonight's session, but you must be present to win. So we'll give all of you a few moments here and wait until about 2/3 of you have responded. All right. A few more moments here. And let's take a look and see what you selected. It looks like in first place was the internal carotid arteries, and in second place was the anterior spinal artery. Let's take a look and see what the correct answer is. And the correct answer is E, subclavian arteries, and 16% of you got it right. Definitely a challenging question. Let me hand it off to Paras.
Thank you, Sean. Yes, definitely a tough question here. So this is a cool diagnosis though. So this patient is having occasional loss of consciousness when tilting his head back, okay? We highlighted that, we made note of it. We also highlighted all of his medical history, but also his surgical history. He had a carotid endarterectomy, he had a AAA, So all of that, along with the smoking, diabetes, hypertension, really should make you think that this guy is like walking atherosclerosis. Like he's got atherosclerosis in a lot of his vessels, okay? So let's talk a little bit about anatomy, okay? So there are a couple arteries that are the first branches off the subclavian, okay? So the right and left vertebral arteries are the first branches off the right and left subclavian arteries, okay? So let's take a look at the next slide, and hopefully this will help explain it a little bit. So you can see there that off the subclavian arteries, the right and left subclavian arteries, the first branches are the right and left vertebral arteries, okay? They then fuse to form the basilar artery, okay? Now, if you have a blockage in the subclavian artery, as indicated by that diagram, okay? If you have a little blockage there, and it's proximal to the vertebral artery, so that blockage in the left subclavian artery is proximal to the left vertebral artery, okay? Vascular demand from that arm, so the left arm, let's say the patient's using his left arm extensively, or let's say he's maneuvering himself, vascular demand can actually cause blood to flow in a retrograde fashion. So it'll actually flow down the vertebral artery, and you can see those red arrows and those downward arrows of blood coming down the left vertebral artery and then going into the left subclavian artery to supply blood to the left subclavian artery, okay? Because it was not originally being supplied because there was a little blockage there, okay? So the blood supply is essentially being stolen from the brain, okay? You have less blood flow going through the basilar artery, and it's actually being stolen by the left vertebral artery and then going to the left subclavian. So hopefully those arrows in that diagram explains it. So this blood supply is stolen from the brain. So this is what we would call subclavian steal syndrome, okay? The subclavian artery is stealing blood, so it's called subclavian steal syndrome. And this can result in syncope, it can result in transient loss of consciousness, and also blood pressure differences between the arms as well, okay? So that's why the subclavian artery is the best answer choice here. And if we go back to the question and look at the answer choices, we can see that how now that occlusion of a subclavian artery could produce subclavian steal syndrome, okay? Let's talk about the other answer choices and why those are incorrect. So, internal mammary arteries D, interestingly, you can actually have a steal syndrome with these arteries, okay? Now, these arteries can be used for CABG, or coronary artery bypass graft surgery. And you can have a coronary artery subclavian-like steal syndrome, okay? However, this is typically associated with coronary ischemia and not neck extension, okay? Answer choice C, internal carotid arteries. These are branches off the common carotid artery, okay? But loss of consciousness from tilting the head back would not be a result of these occlusion of these arteries, as we just mentioned. And same thing going for the external carotid arteries. Those are also coming off the common carotid as well. Anterior spinal artery, these are branches of the vertebral arteries, and these supply the anterior portion of the spinal cord. So if you have interruption of these blood flows, you can affect the corticospinal and spinothalamic tracts, but you would have motor deficits and things of that nature. Not what we're having in this question. So a tough question here, but the first step was figuring out that diagnosis, and then step number 2, knowing the pathology. So tough question here, but great job on working through this question.
All right, well, great job, everyone. I know that was a tough question, but like I said, you are going to have tough questions on test day. If you knew the material and you missed it, or if you missed it because you didn't know the material, either way, you know, whatever that deficit is that you're having, whatever the issue is that you're encountering, or if you don't know what it is and you want us to help identify it, reach out to us at rx-coach, rx-coach.com. Let us take the guesswork out of it and let us help you. So let's go ahead and move on now to our last question of the evening. Remember, we do have a very special offer for all of you in attendance, and one lucky winner will win our raffle. Which of the following medications is the most appropriate anti-epileptic medication to add to her regimen? Which of the following medications is the most appropriate anti-epileptic medication to add to her regimen? I'll give all of you a few moments here to let us know in the question box how many steps you believe this question will require, and then we'll move on to the lead-in. All right, I see the responses coming in. Let's go ahead and read that vignette. A 6-year-old girl is brought to the emergency department after a seizure. She has known epilepsy and currently takes valproic acid. 3 previous monotherapy regimens have failed to treat her epilepsy. Which of the following medications is the most appropriate anti-epileptic medication to add to her regimen? Once again, we'll let you start identifying the important clues as I hand it off to Paris.
Thank you, Sean. So once again, we're going to walk you through what we think are the important clues in this vignette and the lead-in. And hopefully after doing this for these examples, you can start to pick up really on what we're thinking is important to make note and highlight. So when you go back, you can save time and really just have highlighted what's important, okay? So here we actually have a pediatric case. So a 6-year-old girl, why is she brought into the ER? Well, she had a seizure. We know she takes valproic acid for known epilepsy. And we also know that she's previously failed a couple other medications. Okay, we're not told which ones, but we know she's failed some. So then they ask us which medication is most appropriate to add on, specifically an anti-epileptic medication. Okay, so how many steps is this question? I think you could argue this is maybe a one-step question. Just which medication to add on. You could argue that maybe there's a second step here of knowing other things, what's safe, things like that. But I think for the most part, just using the knowledge you have to pick a medication to add. So let's go ahead and take a look at those answer choices. And once again, we're going to start at the bottom and work our way up. Answer choice E, phenytoin. D, levetiracetam. C, lamotrigine. B, felbamate. And A, carbamazepine. So we're going to go ahead and open up that poll. Go ahead and select the one that you think is most appropriate to add. We'll talk about it in just a few seconds.
All right, this is our last question of the evening, so let's try to finish strong. We'll give all of you a few moments here, and then of course, we will have our special offer for all of you in attendance, as well as a raffle for one lucky winner. We hope to see you all next week, same place, same time, 8 p.m. as we do a question dissection on the topic of psychiatry. All right, see the responses coming in. We'll give all of you a few more moments here. All right. Well, let's take a look and see what the audience has selected. Looks like it was close. In first place, we have phenytoin. In second place, we have answer choice D, levetiracetam. And then in third place, we have carbamazepine. So let's take a look and see what the correct answer is. And the correct answer is indeed D, and 27% of you got it right. Another challenging question, but pay attention to Paris now, and you'll get it right on test day.
Thank you, Sean. Yes, definitely another tough question. So we know that this patient is having some difficulty controlling her epilepsy, okay? So we do know we need to add another medication on likely, okay? The one thing we know is she is taking valproic acid, okay? So going back to our pharm knowledge a little bit, this is tightly protein bound and inhibits cytochrome enzymes, CYP enzymes, okay? It also inhibits glucuronidation, okay? So it has a lot of interactions with other drugs, okay? So let's take a look at the next slide, okay? On this slide, you can see some of those option choices, okay? So we know VPA, or valproic acid, inhibits CYP enzymes as well as glucuronidation, okay? So if we take a look at phenytoin, we can see there that one, it is a potent inducer of P450, okay? And it's also largely metabolized by glucuronidation. So right off the bat, we know that there's an interaction with phenytoin, okay? Lamotrigine, let's look at answer choice B, C. This is also, it's not listed here, but it is also primarily excreted by hepatic glucuronidation, okay? And that is inhibited by valproic. So levels of lamotrigine would be increased if you pair these two medications. And that would not be a good thing, especially because this can cause some serious skin side effects as well, okay? Then let's look at carbamazepine. You can also see there that it is an inducer of cytochrome P450, okay? So that also would have drug interactions with valproic acid, okay? So levetiracetam, or Keppra, that is probably the safest drug there. It is not metabolized by the CYP450 system, and it's mostly excreted by the kidneys. So looking at the other answer choices, this is probably the best answer, and it is actually one of the more commonly used anti-epileptic medications as well. Just to round it out, felbamate, that's not used very commonly, but that also increases the toxicity of BPA, so would not be a good answer choice as well. So this is kind of using our farm knowledge and also a little bit of our basic farm knowledge about CYPs to help answer this question. So tough questions today, but great job overall. And I will hand it back to you, Sean.
Well, thank you very much, Paros. We did have a ton of challenging questions today. All of them more challenging. But like I said, we are going to have challenging questions throughout our careers, whether it's in medical school, on board exams, or even challenging cases in real life. So it's important to know how to think through these and be confident when you're answering these questions. And the way you're going to be confident is by practicing and strengthening your foundation of knowledge. So once again, if you want, you can always reach out to us at rx-coach or rx-coach.com. These are the question IDs from this evening. You're welcome to take a screenshot or jot these down. Then you can actually go online if you have our question bank and type these into the RX search field and review these as you're studying.